Welcome, members, to Radiology Without Borders, where we usually present different cases in our medical imaging setup. This is Blessed Khondowe, medical imaging specialist, working with the Mzuzu Central Hospital Radiology Department, Malawi, in Africa. Today, our talk will be about contrast aspiration. Contrast aspiration is something that happens when contrast media, which we use to study the GIT, instead of going to the gastrointestinal tract, it goes to the airway. So our outline includes the introductory part of contrast aspiration. Then we go to choice of contrast medium used in contrast swallow. We will also have a talk a bit of penetration and aspiration rating scale. This scale is just a scale which is used to help in communicating the degree of aspiration or penetration that has happened because of different reasons. This one helps us to communicate uniformly to our referring physicians on the degree of aspiration that we are dealing with. Finally, we are going to have a look at the case that we had at Mzuzu Central Hospital, where a patient aspirated contrast. So contrast is just a chemical agent that is used to help in visualizing or characterizing the pathology or anatomical organs that have low density. In this, what it means is there are some anatomical organs in the body that do not have much needed density or thickness that can outsmart other organs. For example, gastrointestinal tract is a soft tissue organ or a hollowed organ, which is having less dense compared to the bones which are lying posterior to it. So for us to study this tract, we are supposed to put in contrast agents, which is in form of a dye, which is taken orally. It fills the lumen. Then the density of this tract becomes more than the density of the bones, hence evaluating the pathological processes that are going on in this hollowed organ. So aspiration is a term that is usually used when the material that passes supposed to go to the gastrointestinal tract, like in this case, the esophagus, passes to the larynx and goes beyond the vocal cords. But when the contrast or foreign material does not go beyond the vocal cords, this one is termed as penetration. This is just a schematic or gross anatomy of the esophagus and the larynx. You can agree with me that here we have our mouth, where contrast is usually taken, of course, propelled with the help of the tongue to the oropharynx. Oropharynx, the anatomical area where it is adjacent to the oral cavity. Then the epiglottis, which is helping us to cover the larynx, where the airway starts. Then if this epiglottis covers here, it allows the contrast to go down to the esophagus, while this oropharynx, this larynx is closed using the epiglottis, which abuts the cricoid cartilage. So if the contrast in one way or another has gone to this larynx and does not go beyond the vocal cords, which sits around here, it means there is penetration that is taking place. And if contrast has gone beyond the vocal cords down here to the trachea and to the bronchus down, as well as up to the bronchial tree, which goes in the lungs. It means we are dealing with penetration. So in this image, just want us to appreciate the airway where contrast goes in the process of aspiration. This is a trachea, and the trachea has two branches, branches of airways, which is the bronchus. This main bronchus, that's the right main bronchus, and this left main bronchus branching on the carina, and these are bronchial trees going to the lobes. So this is just the. Let me just remove this marker, which is giving me problems. So the choice of contrast media, we need to choose the type of contrast media which has a good result to the clinical question that we are dealing with. Gallium sulfate is the most commonly used contrast media orally, and this is the contrast that is widely available. But this barium sulfate has problems when it comes to aspiration because it's composed of some sediments which are metallic. So if the patient has a risk of aspiration, risk of perforation, we are supposed to use gastrography, which is water soluble, but has high osmolarity, meaning that if it aspirates, it also has some problems in the lungs. So if someone has a risk of aspiration, where contrast can easily go into the lungs, through the larynx, passing through the trachea, the best contrast media to use is iohexol, which is low contrast, low osmolar contrast media. This type of contrast media, if aspirated, is easily managed by just some antibiotics, and the patient goes home. But if gastrography has been aspirated, it causes pulmonary edema, and the patient can easily die from this type of contrast aspiration. So some of the complications just brought up with that we have to do these studies with caution because of the harmful effects that can come as a result of aspiration. So caution should be exercised when using water-soluble contrast agents in patients' risk of aspiration, as I've already mentioned. Aspiration of high osmolarity water-soluble like gastrography is associated with pulmonary edema and the subsequent death. And the oral osmolarity agent like iohexol is very good in this setting because of its low or little effects after the contrast, after aspiration. So the fluoroscopic swallowing examination, the aim is to look at the timing of swallowing, mechanism of swallowing, and extent of aspiration if at all we have one. So there are three types of aspiration. The first one is pre-deglutitive aspiration, which is the type of aspiration that happens when the contrast is still in the pharynx. Then the second one is intradeglutitive aspiration, which is the aspiration that takes place where the contrast in the process of moving from the pharynx to the esophagus. Then we have post-deglutitive aspiration. This type of aspiration happens when the contrast have already passed through the pharynx and is in the esophagus. And this one is commonly done when the patient has a stricture. And this stricture or a mass pressing on the esophagus causes makes the contrast to lodge at that level of stricture, and contrast usually goes back. When the contrast comes back, it will find the epiglottis, which covers the larynx, moves back to its position, increasing chances of contrast going into the larynx, leading to aspiration. So this is just a demonstration of how swallowing examinations are done. This is the contrast media in this cup, and the patient swallows the contrast media into the, put the contrast media into the mouth, and the tongue does its work and propels contrast into the esophagus, going down to the stomach. So this is normal barium swallow or contrast swallow with well outlined esophagus from this level of aortic arc to the gastroesophageal sphincter around here. So this is normal in the outline of the esophagus. But if there are some problems like the stricture or the muscles pressing on it, we might see that or there's obliteration of the esophageal wall. So this is just a demonstration of aspiration in a deglutitive phase, which is parapharyngeal phase. We can appreciate that we have contrast media covering the pharynx, the oral pharynx at this level, and the epiglottis has closed the larynx here, and the contrast goes down to the esophagus. So at this level, if there is incompetence in closing of this larynx, definitely we'll have aspiration taking place. Then the next thing to deal with is intradeglutitive aspiration swallowing, where we have contrast going to covering the pharynx. So we can see the whole pharynx is covered by the contrast as at least to go beyond even the esophagus. So at this level, if there is incompetence as well in opening of this larynx, then contrast will go into the esophagus, leading to perforation, to penetration, as well as aspiration if it goes beyond the vocal cords down here to the trachea. The other phase is post-deglutitive, where we have a contrast media going down to the esophagus. So this is the level where I was saying, if at all we have a stricture below the esophagus here, and the contrast powers up here, definitely it will go back and find the epiglottis already comes back to its position, finding its way down to the larynx and to the trachea, leading to aspiration. And if the cough reflex have not been done, definitely contrast will go down to the main bronchus and go to the bronchial tree. So beyond this, we have to look at the scale, which helps us to communicate to our referring physicians. This type of scale was discovered, was established by John Rosbecker in 1996 with his friends, and it gives the categories and the scores where we need to communicate and emphasize on the degree of degree or severity of aspiration that we are dealing with. So the score from 1 to 5 is not aspiration, but rather penetration, where 1 it means there is no any penetration and there's no any aspiration, and the airway is just normal. Our barium is successful. Our contrast swallow is successfully done. Then the score of 2 means there is penetration, because contrast remains in the larynx and does not go beyond the vocal cords, and it can easily be ejected. It means the physicians will just know that there is not anything that we need to worry about the patient. And the score of 3 means contrast is still more in the above the vocal cords, but it's not able to be ejected, which means we need to closely monitor the patient. And the score of 4 is given to contrast, where contrast is in contact with the vocal cords and is easily ejected with cough reflex. And the score of 5 means the contrast is in contact with the vocal cords and cannot be ejected, posing a threat to aspiration, because contrast can easily progress to the trachea. Then aspiration, then we start giving the rate of 6. Then the score of 6 shows, it means that contrast has gone beyond the vocal cords, and sometimes it can easily be ejected. And at the score of 7 and 8 is given when contrast go below the vocal cords, cannot be ejected regardless of the effort that one has given. So the score of 7 and 8 is a strong communication that the patient has a serious problems, because contrast has gone beyond the vocal cords and will possibly go through the trachea, the main bronchus, up to the bronchial tree. Chances are high for that. So the technique for us to do this study, we use usually fluoroscopy, which is standard way of standard equipment for contrast studies. So the patient usually lies should be in upright position or seated, depending on the patient condition, because some patients do not have that energy to stand upright. Because most of the patient who has problems with the esophagus have also problems with eating, which leads to weight loss and loss of energy. So lateral views are the best for evaluation of the esophagus in swallowing examinations, because it views the whole, almost the whole of esophagus. Oblique views are there to help us visualize the esophagus, especially at the level of pharyngoesophageal segment, projecting the shoulder away from the area of interest. And frontal views are also there to help us diagnose the asymmetry of the abnormalities, as well as the masses. If at all there are some masses pressing on the esophagus resulting to difficulties in swallowing, we use the frontal views to see which side is this mass located, and this one helps the surgeons to locate the mass clearly. So this is just a case where I wanted to demonstrate penetration there, where a 55-year-old female was found with an incidental penetration. You can see we have our hyoid bone here, and we have our contrast in the larynx, which is just around here. We have the esophagus, the trachea here, and the esophagus filled with contrast with the well outlined esophagus, and the trachea is just clear this side, anteriorly and posteriorly. There is no contrast, which means this level, at this level, the level of vocal cords about here, around here, it means this is not aspiration as per se, but is penetration. So coming back to aspiration, aspiration is diagnosed when contrast material is seen in the tracheal lumen below the vocal cords, as mentioned. And aspiration is more severe complication than penetration, and may be minimal, moderate, or massive when contrast material reaches the carina and the bronchus, and definitely even the bronchial tree. So aspirated materials in the trachea may generate protective cough to expel them back into the larynx. But if because of one reason or another, there is delay or there is no any cough reflex, then there are higher risks of developing pneumonia, like in this case, when we are using gastrografin, then that is pulmonary edema usually come in. And if we are using barium, then the pulmonary fibrosis or barytosis will also come in. So this is just a patient who has aspiration. We can see 77-year-old male with contrast material penetrating into the laryngeal vestibular and aspiration into the tracheal lumen. We can see this is the trachea, and there is a high dense lining in the tracheal wall. Of course, we don't have it in the posterior aspect, but this one means the contrast has gone beyond the vocal cords and goes to the trachea, which is now termed as aspiration. And this one is, we can also see the airway closure of the, this is a normal esophagus, but the airway closure of the esophagus around at the level of the hypopharynx here has caused the contrast not to go, and the contrast has remained at the level of the pharynx, which means when the epiglottis, which sits around here, goes back, then contrast is likely to go to the opened larynx. So we can see the airway closure of the pharyngoesophageal segment interrupts the passage of the bolus, leaving the residue in the hypopharynx with increased risk of aspiration, as already mentioned. So this is just it's another example of barium aspiration, where a 75-year-old was presented with difficulties in swallowing with a long history of gastroesophageal reflux disease and recent unintentional weight loss. So right lateral and right posterior oblique projections showed contrast outlining in the esophagus, as well as contrast going through the main bronchus and the bronchial tree, which is serious complication as a result of aspiration. So being done with that talk about contrast aspiration, I would like to present you members the case of a 57-year-old non-reactive patient who was admitted to a neurosurgical ward with gradual onset of progressive adenophobia, dysphagia, fever, and weight loss for about 5 months. The patient was taken FPC and RBS were also the samples for FPC and RBS were taken, but the results were not available when I was writing this case. So the patient was referred to the department, which is a radiology department, for barium swallow to rule out esophageal cancer. And this was the X-ray, which was done blindly. Unfortunately, we don't have a fluoroscopy machine at our hospital, so we do these examinations blindly. So this was a frontal X-ray for the patient who presented with difficulties in swallowing. The aim of this chest X-ray was to assess the chest, but there are some pathologies apart from the swallowing difficulties, because we might proceed maybe to do these procedures, these contrast procedures, maybe the patient lungs have serious problems. So if there is aspiration, we use this one as a comparison to the chest that has aspiration. So this is the lateral chest of the patient after giving the patient contrast. And unfortunately, the patient was given barium sulfate because there was no obvious suspicion of contrast aspiration. So this is a lateral barium swallow examination. We can appreciate the contrast taking shape, good shape of the esophagus. But if we go down here, there is a stricture around, or the narrowing or around this area, and the narrowing is not very smooth. And we can also appreciate the coating of the tracheal wall with the contrast media, which is giving us a high dense, and this is not the right way or the normal way of how trachea is presented. And the contrast here has even gone beyond the bronchial, the main bronchus, and goes to the bronchial tree, as we can appreciate. Let us look at the oblique, how it shows. This only confirms that this is the main bronchus, and this is the bronchial tree, and this is severe affected bronchus. We can see that the esophagus is here. In this lateral, there was some degree of superimposition, but this lateral oblique projection has at least helped us to confirm that this is really contrast in the biliary, in the bronchial tree, and not necessarily superimposing in the stomach. So we have little contrast coming to the stomach, which has irregular stricture with the irregular narrowing, suspecting to be a malignant process going on. So this is just a frontal projection, which is also confirms the stricture, which helps us to think that the contrast failed to go to the stomach, and it comes back to the esophagus, to the oropharynx, to the pharynx up here, finding its way into the larynx after the epiglottis relaxed back to its normal position. And this contrast goes beyond the main bronchus, and the lower lobe is the only which is severely affected in this type of aspiration. We can see more contrast seen in the left lower biliary, not biliary, sorry, bronchial tree. So the unfortunate part is that we lost this patient because I hope the management was not very good. So this one is the same patient, just showing the mainly affected lung. In this case, it is the left lung that is mainly affected, because you can see almost the whole lower lobe. We see the bronchial tree is completely opacified with contrast, which was supposed to go to the through the esophagus. And this area of the esophagus, the lower segment of the esophagus, is narrowed with some irregularities within it, mimicking malignant processes going on. And this is the reason why contrast came back and find its way into the trachea. So after this talk, members, I would like to have a little something for us to take home. I would like to advise almost all members of the radiology team to be very much conscious when performing contrast examinations. So if the patient is at risk of aspiration, we are advised to use low or smaller contrast media like the iohexol, which is approved by Food and Drug Administration to be used as an oral contrast. So high or smaller contrast media like gastrografin are contraindicated in patients with the aspiration risk due to significant risk of pulmonary edema, which usually progresses to death because it affects the cardiac muscles. So if the cardiac muscles are affected, definitely there will be inadequate or no pumping of blood to the brain, leading to brain death. So the brain death meaning the death of a patient. Though aspiration of small amounts of barium sulfate is generally not regarded as harmful, but it can cause pulmonary parodosis. Pulmonary parodosis is just a fibrotic process which is taking place after the little barium that has gone to the lungs have overstayed, and this one is a benign process. So someone can stay at least a bit of time with it without maybe showing some signs and symptoms. Aspiration of large amounts of barium sulfate may lead to death because barium sulfate might not be re-aspirated back from the bronchial tree. So if a patient's aspirates initiate an appropriate cough reflex, which usually comes automatically. That's the first means of helping the patient who have aspirated contrast media. Thank you so much, members, for your attention. This information was covered, was gotten from the following references, and you can consult them for further reading and understanding. Otherwise, at this level, I would like to thank you for listening. Thank you. Over to you, my friend.